Hello everyone in CardioMinds channel and welcome to a new guidelines as we are going to discuss guidelines for acute coronary syndrome released in 2023 by the European Society of Cardiology. And the first video that we are going to explain today is the diagnosis and triage of acute coronary syndrome in general. This is the first guidelines to deal with the acute coronary syndrome as a whole spectrum, instead of separate guidelines for ST elevation myocardial infarction and separate guidelines for non-ST elevation acute coronary syndrome. As in both, the patient has nearly the same clinical presentation. Patient may be asymptomatic and the abnormality in the ECG or cardiac biomarkers may be accidentally discovered, or presenting with chest pain or angina equivalent that may be persistent. Sometimes a patient may be critical, presenting with cardiogenic shock and or acute heart failure up to acute pulmonary edema, or unfortunately the patient may present with sudden cardiac arrest caused by myocardial infarction, either STEMI or non-STEMI. Then the ECG may be normal, which does not exclude, of course, myocardial infarction, or sometimes present with ST depression as in non-ST elevation acute coronary syndrome, or ST elevation, and in this case it is categorized as STEMI, or sometimes malignant tachy or bradyarrhythmia. Then we have two working diagnoses, which is the initial diagnosis that you are working on and having a specific pathway for each one of them, either ST elevation myocardial infarction in case of presence of ST elevation in the ECG, or non-ST elevation acute coronary syndrome. In case of non-ST, you arrange for high sensitivity cardiac troponins, which may be non-elevated or there is detectable rise and or fall, and then the final diagnosis is divided into unstable angina, in which the cardiac biomarkers are normal, non-STEMI, which is non-ST elevation acute coronary syndrome with elevated biomarkers, or ST elevation myocardial infarction from the start. Let's remind ourselves with the fourth universal definition of myocardial infarction released in 2018. This is the detection of an increase and or decrease of a cardiac biomarker, preferably high sensitivity cardiac troponin T or I, with at least one value above the 99th percentile of the upper reference limit, and at least one of the following: either symptoms of myocardial ischemia, or new ischemic ECG changes, or development of pathological Q waves on ECG, or imaging evidence of loss of viable myocardium, or new regional wall motion abnormalities in a pattern consistent with an ischemic territory, or intracoronary thrombus detected on angiography, or unfortunately the patient died and it is detected on autopsy. But remember that the definition means detection of rise or fall, so you need two sets of cardiac biomarkers, not just one marker is enough to diagnose MI. What do we mean by a working diagnosis of STEMI? Here the patient presents with acute chest pain or chest pain equivalent and persistent ST elevation or ST elevation equivalence. That's why we call it ST elevation myocardial infarction, without waiting for the cardiac biomarkers. So we have new ST elevation at the J point in at least two contiguous leads. In case of V2 or V3, the cutoff point is more than or equal to 2.5 mm in men less than 40 years, 2 mm or more in men more than or equal 40 years old, or more than or equal 1.5 mm in women regardless of age. In other ECG leads, cutoff point in 1 mm or more is enough to diagnose ST elevation in absence of LVH or left bundle branch block. Another form of ST elevation equivalent is the left main equivalent, which is ST depression more than or equal 1 mm in 6 or more surface ECG leads, called infralateral ST depression, coupled with ST elevation in AVR and or V1. This suggests multivessel ischemia or left main coronary obstruction. Remember that the vast majority of those patients presenting with STEMI will sustain myocardial necrosis, of course, and so they will develop troponin elevation fulfilling the criteria for MI. But remember also that MI will not be the final diagnosis in those patients with a working diagnosis of STEMI. Still, the final diagnosis here is STEMI based on the presence of ST elevation in the ECG from the start. What about a working diagnosis of non-ST elevation acute coronary syndrome? Here the patient has the same clinical presentation of acute chest pain or chest pain equivalents, but without persistent ST segment elevation or ST elevation equivalence on ECG. So the ECG here may be normal, but this does not exclude ischemia or does not exclude myocardial infarction. Transient ST elevation, in which the patient had an ECG outside the hospital showing ST elevation, but when he presented to our hospital, for example, he had resolution of chest pain and the ECG became normal, so this is transient ST elevation. Persistent or transient ST segment depression, T wave abnormalities, like for example hyperacute T waves, but beware that sometimes hyperacute T waves precede the onset of ST elevation, and so the patient in this case will have a working diagnosis of STEMI. Inverted or biphasic T waves, flattened T waves, or pseudonormalization of T waves. If the patient showed a typical rise and or fall in cardiac troponin level fulfilling the criteria of the fourth universal definition of MI, he will receive a final diagnosis of non-STEMI, which represents the majority of patients with non-ST elevation acute coronary syndrome. But if the troponin level is still below the 99th percentile, he will receive a final diagnosis of unstable angina, which is less common, using the high sensitivity troponin assay. Let's discuss some definitions that we are going to use throughout these guidelines. First, medical contact means the time point at which the patient was initially assessed by a physician, a paramedic, or a nurse, or any trained emergency medical personnel who can obtain and interpret the ECG and so deliver initial interventions, example, defibrillation in case of pulseless VT or VF. And so it can be in a pre-hospital setting or upon arrival to the ER. STEMI diagnosis comes after the first medical contact, as it is the time at which the patient with ischemic symptoms was interpreted as having ST elevation or elevation equivalent in the ECG. So STEMI diagnosis comes after the first medical contact. Primary PCI include any emergent PCI with balloon, stent, or other approved device performed on the infarct-related artery without previous fibrinolytic treatment. Whereas primary PCI strategy include emergency coronary angiography and PCI also of the infarct-related artery if indicated. So it is nearly the same definition. The difference here is that CABG may be also indicated instead of PCI in certain circumstances according to the anatomy of the coronaries and whether the patient had Thymus reflow or not. So the patient may be scheduled for urgent CABG. While rescue PCI means any emergent PCI performed as soon as possible in cases of failed fibrinolytic treatment. So 60 to 90 minutes after giving the fibrinolytic if there is less than 50% resolution of the ST elevation, so we schedule the patient for rescue PCI. While routine early PCI after fibrinolysis, after successful fibrinolysis, we perform coronary angiography with PCI of the infarct-related artery if indicated between 2 to 24 hours after successful fibrinolysis. The terminology of pharmacoinvasive strategy means the fibrinolysis combined with rescue PCI in case of failed fibrinolysis or routine early PCI strategy in cases of successful fibrinolysis. So that's why we call it pharmaco, standing for fibrinolysis, invasive standing for rescue PCI or the routine early PCI. Immediate invasive strategy is an emergency coronary angiography and PCI or CABG of the infarct-related arteries that sometimes we use in non-ST elevation acute coronary syndrome with very high risk criteria that we are going to discuss in the next video. Whereas early invasive strategy means early coronary angiography within less than 24 hours from the diagnosis of non-ST elevation acute coronary syndrome and PCI or CABG of the infarct-related artery if indicated in case of non-ST elevation acute coronary syndrome with high risk criteria. Then selective invasive strategy is coronary angiography plus minus PCI or CABG based on clinical assessment and or non-invasive testing, usually performed while the patient is still admitted in the hospital. So this diagram is nearly the same as the first one, as here the patient has a clinical presentation suggestive of acute coronary syndrome, and so we have an ECG within 10 minutes of the first medical contact. Then he is having a working diagnosis of either STEMI or non-ST elevation acute coronary syndrome. We arrange for further investigations as high-sensitivity cardiac troponins in case of non-ST elevation acute coronary syndrome, plus minus coronary angiography according to the clinical status of the patient, plus minus cardiac imaging. Then we have final diagnosis of STEMI or non-STEMI or unstable angina, but we have here a fourth final diagnosis, which is non-acute coronary syndrome diagnosis, because the patient was non-cardiac and the clinical presentation was confirmed to not be acute coronary syndrome. Let's give a brief regarding the clinical presentation. The chest pain descriptor should be classified as either cardiac pain, which is a typical chest pain suggestive of acute coronary syndrome, possibly cardiac pain that it may be anginal, may be non-anginal, and the last one likely non-cardiac pain that sometimes we describe as atypical chest pain. But this terminology should be avoided because sometimes it may result in misdiagnosis of a non-cardiac condition, and so the patient may have MI and it may be missed due to assumption that this pain is atypical. We better to describe it as likely non-cardiac, but there is still a possibility that it may be acute coronary syndrome. Then we have some chest pain equivalent symptoms that include dyspnea, epigastric pain, diaphoresis and dizziness, pain in the left or right arm, pain in the neck or jaw. So these symptoms should raise awareness of acute coronary syndrome even in absence of chest pain, because sometimes they may be the main presenting symptom suggestive of acute coronary syndrome. And don't miss the red flags like prolonged chest pain more than 15 minutes or recurrent pain within 1 hour. This diagram summarizes the clinical presentation of acute coronary syndrome. As in 80% of the cases, either males or females, they present with chest pain or likely compressing chest pain. Sometimes the patient may present with diaphoresis, epigastric pain, sense of indigestion, shoulder or arm pain that are considered anginal-like symptoms or anginal equivalents, but don't miss that in females some symptoms may be more common, like dizziness, nausea, vomiting, jaw or neck pain, shortness of breath. In these cases, you should arrange for ECG plus minus cardiac biomarkers, because these clinical presentations may suggest acute coronary syndrome despite absence of chest pain. After analyzing the symptoms, we have a differential diagnosis that, of course, the first possibility is a cardiac pain that may be caused by angina, but also it may be caused by myocarditis, pericarditis, cardiomyopathies, tachyarrhythmia, acute heart failure, hypertensive emergency, Takotsubo syndrome, coronary spasm, or cardiac trauma. There are pulmonary causes like, of course, the most important pulmonary embolism that may present with chest pain and sometimes even anginal pain due to the RV strain, tension pneumothorax, bronchitis, pneumonia, or pleurisy. Vascular causes like the most serious aortic dissection that in case of chest pain radiating to the back plus minus unequal blood pressure on both sides, you should suspect aortic dissection or symptomatic aortic aneurysm. Gastrointestinal like esophagitis, reflux or spasm or gastritis or pancreatitis. Orthopedic like musculoskeletal disorders, muscle injury, costochondritis, or other causes like anxiety, herpes zoster like preherpetic or postherpetic neuralgia, or anemia. Regarding nitrates, of course, when a pain is relieved after nitrate administration, it may increase the likelihood of acute coronary syndrome, but not specific, because sometimes esophageal spasm may be relieved by nitrates. Also, in a patient with a working diagnosis of STEMI, don't depend on nitrates, as it may be misleading and not recommended as a diagnostic maneuver. In most of the cases of STEMI, the pain will not be relieved by nitrate due to occlusion of the coronary, and in case of complete normalization of the ST elevation after nitrate with complete relief of symptom, this may suggest coronary spasm plus minus myocardial infarction. Then we are going to have a focused physical examination relevant to the symptoms. So for example, cardiac auscultation showing a systolic murmur, it may be caused by ischemic mitral regurgitation or ventricular septal rupture, which are mechanical complications of MI associated with a poor prognosis. And if there is an early diastolic murmur suggestive of aortic regurgitation, this raises a suspicion of acute aortic dissection type A. Sometimes examination may show signs of non-coronary causes of chest pain or other extra cardiac pathologies, and if there is a difference in blood pressure between the arms, if there is irregular pulse, congested neck veins, friction rub, or pain reproduced by chest or abdominal palpation, these are suggestive of other alternative diagnoses. So the recommendation regarding the diagnosis of acute coronary syndrome to combine clinical history, symptoms, vital signs, and other physical findings, ECG, and high sensitivity cardiac troponin to have a working diagnosis and then a final diagnosis. And this diagram is very interesting, as here it uses 3 letters of acute coronary syndrome. A standing for abnormal ECG to assess for evidence of ischemia, but normal ECG does not exclude myocardial infarction. Clinical context, which is to consider the clinical risk factors and comorbidities of the patient and the presentation, and S for stable patient regarding clinical and vital stability. What are the recommendations regarding ECG? Of course, 12-lead ECG should be performed within less than 10 minutes from the first medical contact, and continuous ECG monitoring with defibrillator capacity should be available for all patients with suspected STEMI, suspected acute coronary syndrome, or other ECG changes either in the ER, in the CCU, or in the chest pain unit. Use the additional ECG leads like right or posterior ECG leads in cases of inferior STEMI, or if there is total vessel occlusion is suspected and the standard 12-lead ECG is inconclusive, and if the first ECG was apparently normal, repeat a follow-up 12-lead ECG in case of recurrent symptoms or diagnostic uncertainty. And if there is evidence of ST elevation in the ECG, so this patient has a working diagnosis of STEMI and should be immediately triaged for an emergency reperfusion strategy. This diagram summarizes the ECG features that we can see in patients with acute coronary syndrome, either new ST elevation at the J points in 2 or more contiguous leads with the criteria that we mentioned, evidence of posterior STEMI either in V1 to V3 showing ST depression with upright T waves, or ST elevation in the posterior ECG leads, or using the right ECG leads to diagnose right ventricular infarction, and evidence of left main equivalent in the ECG suggestive of multivessel ischemia or left main obstruction, presence of left bundle branch block or paced rhythm using the Scarboza criteria to differentiate acute from chronic left bundle, and presence of right bundle branch block that may raise high clinical suspicion of ongoing myocardial ischemia that should be managed in a similar way to STEMI patients. Also, presence of isolated T-wave inversions that may suggest mildly impaired prognosis, but the presence of ST depression with a higher magnitude and a higher number of leads suggests ongoing severe ischemia, and transient ST elevation suggests high-risk non-ST elevation acute coronary syndrome. The winter ECG changes with 1 to 3 mm upsloping ST depression at the J point in V1 to V6 with hyperacute T waves, or the Velen sign either type A or type B suggesting proximal LED occlusion or severe stenosis. What about the cardiac troponin? Let's raise some facts. First of all, the rule comes after exclusion of STEMI or very high risk non-ST elevation acute coronary syndrome. As in this case, we don't need cardiac troponin. The patient should be triaged for emergency reperfusion. In patients with MI, the level of high sensitivity cardiac troponin rise within 1 hour after symptom onset and remain elevated for a period of 10 to 14 days, so it has shorter blind interval than the standard cardiac troponin. The detection of rise and or fall in the cardiac troponin differentiate acute MI from chronic myocardial injury, but not from acute myocardial injury, because also in acute myocardial injury caused by non-MI causes, there is detection of rise and or fall, but in absence of the other factors that we mentioned in the fourth universal definition. Presence of one of them with the detection of rise or fall diagnose acute MI and differentiate it from acute myocardial injury. Use of the terms normal and abnormal to describe the high sensitivity cardiac troponin should be avoided. Instead, use the terminologies of non-elevated or elevated troponin in order to refer to the level below or above the 99th percentile. And last, cutoff level for both 0 1 hour or 0 2 hour algorithms are assay specific. So depending on the type of assay that the laboratory is using, in this case we determine the cutoff limit. We have two types of cardiac troponin assay: the central laboratory or point of care test. So central laboratory is the vast majority of the assay, in which you withdraw a blood sample from the patient and sending it to the lab, which is sensitive in detection of cardiac troponin in 20 to 50% of the cases, or high sensitivity allowing for detection of cardiac troponin in 50 to 95% of healthy individuals. High sensitivity assays, of course, here are recommended over the standard lower sensitivity assay because they provide higher diagnostic accuracy and a higher positive predictive value at an identical low cost. Whereas a point of care test is using a strip in order to measure the cardiac troponin rapidly beside the patient as a bedside test with a shorter turnaround time. However, this is not a high sensitivity troponin as a central laboratory, so it shows lower sensitivity, lower diagnostic accuracy, and lower negative predictive value. So in this case, the clinical decision here may be less accurate than sending a blood sample to the central laboratory. There are some clinical variables or confounders that may affect the high sensitivity cardiac troponin concentrations beyond the presence or absence of MI. For example, the age. The older the age of the patient, the higher the level of high sensitivity cardiac troponin, up to 300%. Presence or absence of renal dysfunction. The lower the GFR, the higher the level. Time from chest pain onset, and the longer the time, the higher the level. And of course, sex may affect the cardiac troponin level to an extent of 40%, but this is the least powerful confounder. However, still the absolute changes in the levels are of diagnostic and prognostic value regardless these confounders, and so use the uniform cutoff concentrations decided by the laboratory in order to decide whether this patient is having elevated or non-elevated cardiac troponins, and so allow for an early diagnosis of MI, but pay attention to these confounders. So in summary, high sensitivity in comparison to standard cardiac troponin assays have a higher negative predictive value to exclude acute MI, especially in case of early presentation, and reduce the troponin blind interval, as here we are speaking about rising after 1 hour, whereas in a standard troponin rise after nearly 3 to 4 hours, result in a 4% absolute and 20% relative increase in the detection of type 1 MI, and so decrease in the diagnosis of unstable angina, and twofold increase in the detection of type 2 MI. And don't forget that the levels of high sensitivity cardiac troponin should be interpreted as quantitative markers of cardiomyocyte damage, not just positive or negative. So the probability of MI increases with the increasing level of high sensitivity cardiac troponins. Elevation beyond 5-folds the upper reference limit have high positive predictive value for acute type 1 MI, and elevation up to 3-folds the upper reference limit have limited positive predictive value for MI. So the higher the level, the higher the probability, and so it is common to detect circulating levels of cardiac troponin sometimes in healthy individuals, and due to the high sensitivity cardiac troponin levels can be elevated due to acute and chronic conditions other than MI. What about the other biomarkers? So far, not recommended to be used unless cardiac troponin is not available. For example, CKMB, myosin binding protein C, or co-peptin. Sometimes they may have clinical relevance when they are combined with the standard cardiac troponin. However, in most clinical situations, their incremental value above and beyond cardiac troponin is limited. So, whenever possible, use troponin. Better to be high sensitivity. Not available, use the other biomarkers. So this diagram summarizes how to use cardiac biomarkers. We have a patient presenting with suspected non-STEMI, but without an indication for immediate invasive strategy. For example, STEMI or very high risk non-ST elevation acute coronary syndrome. So we take high sensitivity cardiac troponin at 0 hour and then at 1 or 2 hour interval. Either the patient is having very low initial high sensitivity cardiac troponin, which is only applicable if the chest pain onset was more than 3 hours prior to the 0 hour high sensitivity measurement. But don't depend solely on this idea, because sometimes the patient may have very low initial value, but as the full text of these guidelines mentions that sometimes according to the clinical context of the patient you need to have another follow-up sample. Or the patient is having low initial high sensitivity cardiac troponin with no increase in the 1 hour or 2 hour interval. In this case, the patient is ruled out of having MI, but even after excluding MI, some patients may be indicated for elective non-invasive or invasive imaging according to the clinical and risk assessment. If the patient is having high initial high sensitivity cardiac troponin, or in the follow-up 1 hour or 2 hour intervals there was a detectable increase, so this patient should be ruled in as MI needing hospitalization and invasive coronary angiography. Otherwise, if the patient is not meeting the criteria for rule-in or rule-out pathway, so he is included in the observe pathway, needing another third sample to confirm or exclude. This table summarizes the other causes of elevated cardiac troponin, like for example type 2 MI showing oxygen supply-demand mismatch, either reduce myocardial perfusion or increase myocardial oxygen demand. Sometimes other causes of myocardial injuries that may result in elevated cardiac troponin, like other cardiac conditions or systemic conditions that may result in elevated cardiac troponin, not due to MI. So the recommendations regarding cardiac troponins that you should measure it with high sensitivity assay whenever possible, immediately after clinical presentation, the 0 hour sample, and the results should be obtained within 60 minutes of blood sampling. The problem is that in some hospitals the result may be delayed up to 2 or 3 hours. This results in a longer stay in the ER and of course delay to diagnosis. And it is recommended to use either 0 hour 1 hour or 0 hour 2 hour algorithm to rule in or rule out non-STEMI. Of course, the use of this algorithm instead of 0 hour 3 hour algorithm reduces the delay to diagnosis, stay in the ER, and diagnostic uncertainty for the patients. Additional testing after 3 hours is recommended if the first two measurements of the 0 hour 1 hour are inconclusive and no alternative diagnosis explaining the condition have been made. So here the patient did not qualify for the rule out or rule in pathway. He is assigned in the observe pathway. Most patients in this case have a high degree of clinical suspicion of acute coronary syndrome, and so he may show relevant increase in the cardiac troponin from presentation to 3 hours, and he may be a candidate for coronary angiography. And most patients with low to intermediate likelihood for acute coronary syndrome may be candidates for non-invasive imaging after transfer to the ward, for example CT coronary angiographies that we are going to speak about shortly. Risk stratification is performed with the GRACE score, standing for Global Registry of Acute Coronary Events, that depends on 5 numbers including age, systolic blood pressure, heart rate, serum creatinine and CALIP class, and 3 questions with yes or no. Cardiac arrest at admission, yes or no. ST segment deviation on ECG, yes or no. Abnormal cardiac enzymes, yes or no. According to the result of the GRACE score, if it is exceeding 140, so in this case the patient is indicated for early invasive strategy. Regarding the rule of echo, emergency echo has a class 1 recommendation, of course, in case of cardiogenic shock or suspected mechanical complications, and class 2A recommendation in case of diagnostic uncertainty, but it should not delay transfer to the CCU or to the cath lab if there is high suspicion of acute coronary occlusion. What about the role of CT coronaries? There is a great dilemma regarding the indication in acute coronary syndrome. There is a famous Beacon trial that assessed whether a diagnostic strategy supplemented by early CT coronaries improves clinical efficacy compared with the standard care. The results that when it was applied early in the workup of suspected acute coronary syndrome, it was safe and associated with less outpatient testing and lower costs. However, it showed no reduction in the time of in-hospital assay or hospital admission in the CT coronaries arm compared with the standard care. And it didn't identify more patients with significant coronary artery disease requiring revascularization or allowing for early discharge from the ER. Another famous trial, the ROMICAT-II, which assessed ER patients with symptoms suggestive of acute coronary syndrome using CT coronaries in the triage strategy. It improved the efficiency of clinical decision making as compared to the standard care, but it resulted in an increase in downstream testing and radiation exposure with no decrease in the overall cost of care. In the RAPID-CT coronary angiography trial, it showed that the default approach using early non-invasive CT coronaries in patients with suspected non-STE elevation, acute coronary syndrome, did not improve clinical outcomes at 1 year, with a modest increase in the duration and cost of hospital stay. Therefore, a normal CT coronaries of course rules out both obstructive and non-obstructive plaques with a high negative predictive value to exclude acute coronary syndrome with excellent clinical outcomes. But its routine use in intermediate risk patients with acute chest pain and suspected acute coronary syndrome so far is not recommended based on the results of the previous trials. So the recommendation so far that patients with suspected acute coronary syndrome, non-elevated high sensitivity cardiac troponin levels, no ECG changes, no recurrence of pain, in this case you can use CT coronaries or non-invasive stress imaging as part of the initial workup. Pay attention that sometimes CT coronaries may need longer time to control the heart rate for performing the CT coronaries, and the big no that routine early CT coronaries in any patient with suspected acute coronary syndrome has a class 3 recommendation. It is not a routine test according to the clinical context, the clinical suspicion, the baseline creatinine, the heart rate of the patient. We can decide whether to go for CT or not. So we have reached the end of the first video in these guidelines, and our take-home message that a patient presenting to the ER with chest pain, don't just concentrate on the description of the pain, but also focus on A, abnormal ECG or not. But normal ECG does not exclude acute coronary syndrome or MI, clinical context, the risk factors, the whole clinical presentation, S, stability of the patient, whether clinically or vitally, and don't forget that one set of non-elevated cardiac troponin is not enough to discharge the patient in most of the cases. Suspect based on the clinical context, and always admit the patient and have a second sample at 1 hour or 2 hours to rule in or rule out MI. Thank you very much for watching this video, and wait next week for the second video of the treatment of acute coronary syndrome.